please welcome Mike up here. He is going to moderate the panel. We have some questions from the audience. We have some questions that we've seeded to the group, but I'm going to turn it over to Mike.
Thanks, Scott. Well, I've really enjoyed myself so far listening to the wonderful talks today. And I think one of the major themes that I've heard today is all about listening to our users. So I have a quick story, and we'll get to the panel. So one of the great things about being both the CMIO and the interim CIO is I got a page out of a meeting by an angry transplant nephrologist who yelled at me for 45 minutes because his passwords kept getting locked out of the computer. And he said, I can't do this anymore. I'm in front of my patients. I can't get into the system. So I apologized. I said, thank you for the feedback. And I said, we'll get on it. So I called my team and I said, what's going on here? This guy keeps getting locked out. And they pull up his logs and they see that he's mistyping his password over and over and over and over again. And I'm like, that can't be right. This is a really smart guy. You know, he does transplant medicine. There's no way he's retyping his password over and over and over again. So we actually went and sat in his clinic and shadowed him for a day. And so turns out, after we implemented complex passwords, he was messing up the shift and caps lock key because he had 5 different keyboard layouts in all of his clinics. So just simply kind of listening and watching was really, really critical. Then I told them we'd had an issue in RFP and the keyboard should be replaced in about 2 years. So that's kind of the sad part of the story, but it kind of goes to the themes that I think each of these speakers talked about today and how important it is to listen to our end users to see how we can improve our systems, because it can be something so little as just 5 different types of keyboards, or it could be something much more complex like redefining a workflow. So the first question I have here really dovetails off of Adrienne's talk about how she really took the EHR to the next level in terms of optimization and usability. And so I'll turn this over to the panel to elaborate on this. But what has your organization done to involve end users in the optimization process and to improve the usability of the EHR? And then what are some of the biggest wins you've found in usability that maybe you could share as a best practice? So anybody can start with that question.
You're the best practice here.
Yeah, you're new. You have
I've been nominated as the new fresh voice of the meeting today. You know, I think that getting feedback from the users is something that we always want to get, and we ask them for it regularly, but so often we don't get it, and I mean, particularly IT. And I have a great informatics team. I have one of the team here today, and they'll tell you, you know, I go up and I sit with them and I shadow them and I don't get it. But what fascinates me is when the CEO goes around to do employee engagement meetings with the staff, they get an earful. And it does perplex me, and I do get frustrated. And so I think primarily we always have to remember that non-traditional feedback, non-traditional observations is really the best way. We can't just assume that when we say, tell us what your problem is right at this minute, call the help desk, it's HLLP on the phone, we make it as easy as possible. They're not going to do it, and I think that we should not fight that. So I try to leverage non-traditional sources. We have people do rounds to look for Post-it notes that they put on the computer because they don't want to pick up the phone to call the help desk, but they do take a minute to put a Post-it note to say this computer is broken. So we try not to fight the natural urge to not follow directions, and we just try to complement what they have found works for them because they're so busy. So pretty much we do that. We piggyback on CEO events. We look for their little notations. We do the rounding. We have events like that are already in place, governance safety huddles. And during the safety huddles is sometimes when someone is describing an actual adverse event that happened, you hear that there's an actual IT cause to that. Or if that keyboard would have worked, then I wouldn't have had to walk around, and I wouldn't have. So we get most of our feedback around usability in just informal fashion.
Do you have a formal structure for rounding by your IT group?
Yes, we do. Our rounding, I do rounding, executive rounding, and then we also have the informatics team who teams up with one of our desktop support. So we take one of the clinicians who understands the workflow, and we team them up with someone who's kind of more desktop. So they could fix it on the fly. Our informaticists may not know, but they're the one that translate it. And sometimes it might be a bit labor intensive, and it's not, I can't say that every single time we can get the team there together, but as much as possible. And we keep a list and we look for trending. Why is one unit tend to have more issues than another unit, or why critical care or something like that. So we do formalize it. It's not an application that we built. It's a spreadsheet that
Great.
we use, but it works.
Thanks, Kara.
I think what I would add to that, and also to the story you told at the beginning, it's really about anthropology. It's resource intensive, but I think you need to go to where the work is. I mean, in lean, it's go to the Gemba. But with all due respect to physicians, it's sort of like Jane Goodall with the gorillas. You need to go kind of live in the clinics or in the inpatient and see what you wouldn't have seen the 5 keyboards had you not actually witnessed that. And we have an adoption and utilization team on the ambulatory side, and it's a 12-week process of pre-engagement and then in the clinic for 2 weeks. And their goal is to address 80% of the things they find before they leave. So there's some pre-training and pre-work. It's just incredibly resource intensive. We could field 2 more teams and just continuously go around. It's the learned behavior. You know what you know. You don't know what you are missing that could make it easier. And so it's really being there. But as I said, that's incredibly resource intensive, and it's very clinically intensive.
Sure. Thanks, John. Any thoughts? Scott? More the same? Great. No, I think that makes a lot of sense, and we have the same struggle. I mean, if you have, say 200 or so ambulatory practices and you're trying to go through each one, it's incredibly resource intensive, but the yields can be quite high, as we've seen. Great, thank you. So the second kind of theme and topic we're talking about is population health, ACOs, clinically integrated networks. So what are your biggest challenges regarding data integration in terms of the sphere of population health and also with analytics? And what differences are there in your strategy for success in between the ACO and CIN type of strategies?
Does this work? Oh, yeah. Well, I think for us, to be perfectly honest, it's a frontier, and so it's hard to share a lot of experiences because we're really on the threshold of it. So at this point, we're doing the meaningful use related things with respect to exporting and importing CCDAs. But if what we're not doing, sort of the next thing, which would be accumulating them on behalf of more than one organization. We accumulate ours, UCI may accumulate theirs, Hoag, same thing. And I think we will have graduated to the next level once we've put it into a place. And I tend to believe and prefer that it be provider-led, I don't want to say controlled, but it is clinical data and generated by people caring for patients. But that's a frontier, and we haven't figured out how we're first of all going to assemble similar data, but not identically labeled. And we have to also be very, very certain when we array data under a person's name that we know who we're talking about. So it's one thing to study a population of diabetics, 10% of whom are mislabeled, but we still know that they're diabetics, and so we can understand what does and maybe doesn't work. It's another thing to know that this diabetic has these experiences. So the bottom line is we're just starting. And right now the exchanges are the simpler ones, the HIE ones, the ones where we're talking about putting things together in a community asset, if you will, just getting started.
Great, thanks, Scott.
One of the challenges that we've been faced with, I think all of us have been faced with it, when everybody started with this, they said, well, you've got to build a clinical data repository, and this was this idea that you build it and they will come. And John talked about the Roach Motel, all the data goes in, it doesn't come out. And the other one is the data landfill, where everything just got dumped in there and nobody uses it either. So We're taking a little bit more of a use case and an iterative approach to this by actually having projects where we understand very deeply what they're trying to do, and we look at the data that they're collecting. We have a hotspotting initiative that we're doing with the Camden Coalition, looking at ED admit problems. And we're basically seeing everything that comes through the ED, and then we're going back and we're saying, what's the root cause of all of this? We're looking at whether or not everything needs to come through the ED, because 70% of our ED visits don't need to be an ED visit, but we get them for lots of reasons. We're finding out that 43% of these patients live within a mile of an FQHP, but they're not going. Why not? So we're seeing that we've got infrastructure that our patients don't know about, that we have places that people should receive care that they're not going. We're looking into just deeply solving a problem, and we're finding that's valuable because that tells us what kind of data we need to collect, and a lot of times it's outside our own walls. So we also find that if all we're looking at is our own segment of the population and our admissions, we're not getting what we need to know about population or community health. And it's getting out into the community and having a specific set of things that you're studying to try to capture that data that's teaching us a lot about what we need and what we're going to need to be able to do meaningful kinds of population health initiatives down the road.
I'd agree with Scott's assessment that we're just in the very, very early stages of it. So it's more conceptual, design on concept or PowerPoint. I think if you define the clinically integrated network as spanning organizational sort of governance and ownership and for-profit, nonprofit, and then technology boundaries, I see two big barriers that are confronting me immediately. One is the gap between vendor hype and reality. So a lot of the reports look really neat. You know, they display well on a PowerPoint, and so there's a lot of enthusiasm about this is really going to be amazing, particularly to look at quality measures across a whole cohort of patients, whether they're in your system or other systems. And I think the ambition, so I don't fault the vendors, I think the ambition is really important and there. The reality, so that's one, is the hype. The second one is why I'm concerned about that is the experience we've had with HIE of trying to get lab orders and results back to a separate system coming into our system, or CCD translation. Leave aside just the technology and the different vendor deployments and is one CCD the other CCD. When we go into a private physician's office, it's usually their niece who set up their computer system. They're not professional IT. They don't have the money and wherewithal. They sort of bought a vendor's product and got it in to get meaningful use, but they're differently happy with their system, but they don't have the support. So when we go in and say, well, does your EMR support MU2 certified CCDA? They're like, what the hell are you talking about? And so I worry about that because we're trying to, we're pinning population health on this ability to move data between private physicians' offices and our medical center, and it's like we're the 800-pound gorilla, and that gorilla's kind of theme. That we're the large, megalithic organization, and I don't know who's going to be on the other side helping us.
Yeah. I think that's a really good point. One of the things that I struggle with a lot, and I often push back on, is what is population health? So we get asked a lot of times, okay, we want your system to do population health, or we want to do population health. What is population health? And it can be defined many different ways. So I was wondering if you guys might want to talk about the different definitions you've heard of population health, and what are some of the kind of themes, I guess, in population health that you're focusing on, because it's obviously a very broad and undefined topic.
Make it in the cloud, powered by big data, and you get them all.
Right, big data, of course.
Big data.
So at Methodist Hospital, we don't really use the term population health that much, and I think the answer for that is we don't have significant amount of at-risk contracts which would drive behavior that we needed statistics of looking at a population to drive their health, if you use that as your definition. Now, we are not an ACO, and we're having very vague discussions about a clinically integrated network, but what we are involved in is bundled payments program. So from a bundled payments program, we're looking at cardiac patients and orthopedic patients, yes, we now have to look at patient populations according to those that we selected. So I guess we are doing population health if that's the definition. Now, population health, is that a verb? Is that an activity? You're managing a population? When I think about data, I think more about analytics. So our discussions have been more around analytics and not population health tools. And that then creates this bigger discussion around definitions again, and what is data and data governance. And these are not concepts that my organization is familiar with. This is a new frontier, as what Scott said. We all got in a room, and our first goal was current state. Okay, let's just document current state. Do we even all know what each other is looking at today? And it was a fascinating exercise because everybody just thought they were the only ones pulling the data, and they had the best data, and their data was, had the most integrity and was the most accurate and the most real time. And what this exercise demonstrated is that everybody had different data, and it was all okay. But if we are going to move to an enterprise model at some point, we do have to have difficult definitions about what is the source of truth and what are the data definitions that will equate these things to a true population health across the enterprise when these big risk-based contracts come in front of us. They're just not there yet, but we are starting to prepare and have those discussions. And I've got to tell you, the current state stuff, everyone was so excited, and we were productive, and we had deliverables. And now that we finished that kind of easy task and we're starting to talk about data management and data governance, these are not fun meetings. There's a lot of arguing. There's a lot of confusion. And we've stalled a bit and are going back and refocusing with some best practice information. I agree with Scott. I reference often Gartner and Advisory Board, and they have some really good documentation about some models of maturity that we're starting to reference just to get us kick-started.
Just to add a couple of things to that, sometimes better is the enemy of good enough, and it's a matter of getting started. But if you think about it from a clinician's viewpoint, if you knew, and this is why I think the problem is just so fundamental and so important, if you knew a patient's problems and you knew what medications they were on, as a clinician, you're 80% down the road to having some idea of what to do. So we don't need to perfectly collect every piece of information. We need to accurately collect it, to be sure. But if we just access the pharmacy data and the like, I think we can make tremendous progress. But there's another part of it too, and just sort of a hypothesis or maybe a premise. Patients don't really want to be managed. It's incredible that in the last 6 weeks of life, we'll spend your life savings, $250,000, in a very, very ugly, unfriendly environment called the ICU. It's just American culture. But we won't spend 10 minutes, a few years earlier in life to maybe forestall that information or that situation. We're not very, very good at that. And unless we can really get those patients engaged and inclined to grab a hold and take responsibility for their health, we're going to have some trouble. So we can do all these other things perfectly, but we somehow have to, the silver bullet lies somewhere in the engagement, which fundamentally I think is going to come down to incentives. So I think, we have a ways to go there, and one of the ways we're trying to learn is work with our own employees. And I don't mean to suggest they're all guinea pigs or whatever, but we've said, we're in the population health business. Can we provide population health services to our own employees? Mm-hmm. And the first thing we realize is they live all over the place, including out here, where we really don't have much in the way of facilities. We don't have all the partnerships and affiliations we need in place. So we first, it's like, as I was saying earlier this morning, you got to have the geographic reach, and you got to have the capability depth, or you have nothing really to sell other than your specific services in your specific market. So we're trying to array those things, and not necessarily by buying it all, so that we have the capability. But in parallel with that, we got to figure out what's it take to get somebody involved with their health before they actually have a way in advanced disease. Because between here and there is a whole lot of money and a lot of lost life. So that's the challenge. It's not all about technology.
One of the things that I've wondered too, and unfortunately I don't remember the reference, so you'll have to forgive me, but I'd always thought that it was our job to get very pristine clinical data, to have good data management, to make sure we had good governance. And all of the things that are coming out of the big search engine companies say you can get better data with a big, messy data set than you can with a very small, precise one. So I'm wondering, how much of our time do we really have to spend working on the pristine collection and standardization of all of this data? Or are we able to kind of step over that if we start sharing it enough? And certainly our vendors are bringing that up to say, why don't you dump all your data in here and use the search engine capability to kind of bypass all of that? And will that give us enough to work with? So I think the challenge for a CIO is I read this stuff and go, what the heck am I supposed to focus on? Because we all know what the rules are. And our own organizations want to do things. And with regard to population health, we're looking more at community health. We're looking at our neighborhoods, our diversity, the patients we have to take care of, the patients we need to see in our hospitals. What services should we have? How should we take care of them? How can we avoid having them come to the wrong place for care? It's a much more intimate kind of local conversation for us. So I don't think there is a definition for population health is the answer. It's personal to every group that you talk about.
That's a great point. I think one of my favorite definitions of population health is things that you do to improve the health of patients that doctors do not have to do. And so like using all your external, providers of care, using technology in some way, and it's never going to be, perfect data, but to take that burden off of physicians so they can continue to check all the boxes for meaningful use stage 7. So that's definitely coming. So I think that's really great. And I think the other thing about patient engagement makes a lot of sense. I mean, we struggle with that. People will go to a football game and wait in traffic and pay from $40 in a parking lot and pay all this money for tickets, but to get them to come to the physician is completely different. However, it's very easy to buy tickets on Ticketmaster, but it's very hard to make an appointment to go see your physician. And even for myself, it's really hard to make an appointment. So I think using some of the technologies to engage patients, but also make it easier for them just to come to the physician is going to be part of what we're going to be tasked to do in the future. So thank you on that. And I also kind of want to shift gears a little bit because I think also a lot of what we have on our plates as CIOs is security and infrastructure. So, what are you most concerned about in terms of maintaining a secure, reliable EHR platform? And if you could grade yourself on reliability, kind of from an A to an F, A being the best. And finally, what services do you envision will fall out of your portfolio in the next 10 years? And what services may you pick up? So a couple different questions there, but very interested to hear your responses to that.
Okay, so let me just pick one of those questions and start there. And I would like to talk about security because it is one of the top 3 things that keeps me up at night. It's another area which I believe healthcare has not been current in keeping up with industry standards across other industries. We don't necessarily default to NIST and ISO and COBIT. We make up our own guidelines of what is tolerated by our clinicians. That's what we have been able to do in the past, and we can't do anymore. So when you start to implement formal standards like the rest of the country, it becomes very difficult. First of all, it's very expensive. There's people who now have security budgets that are the same percentage of operating as their IT budgets. I mean, that's stunning. Those are costs that people are not prepared to deal with, but it actually should be a best practice. Our biggest risk beyond just having the correct staff and correct funding is really the users themselves. It always goes back to the people who are clicking on the emails because they don't know any better. So my biggest risk is still my users. They can't help themselves. If it says you have a UPS package, please click here for the tracking number. They can't help it. They do it, and they don't understand the damage that can cause. So, and sometimes it's even things like vendor access. So we have to have vendors have access to our systems, and this should be a trusted relationship, and we have a BAA, but these are introducing risks that we have to go back and revisit all of these previous policies and procedures because the era of security and risk is just so heightened.
Yeah. We had a breach recently. It was 180 patients, and when you hear the story, I mean, it just could happen to all of us. It was a paper breach, not an electronic one, and it was the manager of surgical services, and they're doing a sort of time and motion study. So it's not really the medical record, but time and motion study of coming into the OR and then leaving the OR. And what she did was printed patient labels, 180 of them, 180 patients for the next period of time, and was going to work at home because she couldn't do the work at the daytime. She left it in a bag, left the bag in her car when she went into the market, and the bag was stolen out of the back of her car. Now, the person probably saw this, had no idea. I mean, they weren't targeting, maybe this person has medically, but it was medical record number, date of birth, full name, all that sort of thing, and the surgical procedure to happen. So, I mean, it didn't rise to the 500. I think California has stricter laws, but in Oregon, 500, you have to do the press notification. Lower than that, you got to go to each of them. And when it came to it, it was someone who's actually using her own time to do the work of the organization at home, an innocent thing, unintentional, and just the ease of it. A laptop stolen, a fishing expedition that actually causes a breach. And it's sort of like what we've started with the audit committee, and thank God our board audit committee is adopting this language. It's not if this will happen, it's when it happens. So we've started we have cyber insurance, which you all probably do, and we've started the conversation with them about, I want your 866 number on my short list on my cell phone, because I want the attorney, I want the media person, and I want the forensic specialist, because this is stuff I don't know anything about. But when we have a hint of it, I want to bring the experts fast. And that, I think, is no matter what technology or education we put into place, when you have state-sponsored persistent attacks that go over a long period of time, no healthcare organization is going to pay enough money to, going to that 100% of risk remediation is not cost effective.
You asked the question about things that may fall in or fall out of the portfolio, and just pure speculation on the one hand, and in the other case, something waltzed its way into my portfolio recently. In the former case, we're clearly in the information business. Yes, we're in the care delivery business, no question, but it's information powered, and we're really in the information business. And I think analytics right now is the domain of the CIO sort of by default. I think over time it's going to migrate its way out into, something more broadly controlled, more democratic, or in some cases headed by people that are more skilled, real data scientists, if you will. So I can imagine relinquishing that in some fashion, except for the technology that underpins it. Don't know, we'll see. On the other hand, I was asked, wrong place, wrong time, whatever, so could you oversee research? So I now do that for the organization, and I think there's some validity to it. It wasn't an accident, really. It was an area that we think has opportunity. And when you think about it, it's close to analytics, and it's close to affiliation and partnership, a lot of which we already do with UCI and others. So, your job is going to morph, I guess, is maybe the part of your question, and I can see things changing in that area, but those two things at least.
Thanks. That's great.
When I think of that, I think about not what will fall out of the portfolio as much as how will roles change within organizations to support the technology evolution. So I think a lot about just the deployment of virtualization and how that has created more space in our data centers. And now, do we need traditional storage engineers like we've had before if everything starts to migrate to the cloud? The technology out there is really outpacing some of even the skill sets that we have in-house, and kind of staying current and helping employees think about that. What's it going to look like in the future? What could we call you? Unfortunately, sometimes we get limited by our HR departments trying to put people into slots because they match the, Hospital Association of Southern California's job descriptions, which we have to benchmark to. And I understand that, and that is important, but technology is just changing so much. Informatics positions, I mean, we all heard an informatics position can be many different things in different organizations. It can be education, it can be optimization. I mean, even looking at the traditional analyst, I was thinking about that today is, you know, analyst teams can either be production support or they can be on the implementation team for new implementations. Well, we might get to that point where new implementations are really, you know, decreasing, and it becomes more production support. So what happens to those people who like being on that side of the innovation and the new projects? You know, what will we do with them? How can we migrate them and keep the talent in? You know, I was always have been impressed with what MemorialCare has done with their management teaching and kind of developing in-house. And we should develop our people in-house, but we have to think about these transitions that are occurring, and they're happening pretty quickly, and we want to have people be fulfilled and stay with the organizations. And I think that is what's going to fall out, is just job titles and transitions. So.
Thank you.
I actually asked that question. We have a director of infrastructure strategy. So I called him up and I said, Jay, what's going to fall out of the portfolio? He goes, Adrienne, everything's going to fall out of the portfolio. He goes, we shouldn't be in the data center business at all. What are we doing? He said, I'm afraid to even bring it up around here because everybody seems so wedded to the data center, but what the heck are we doing? He came from Citigroup. We brought him in on purpose because he doesn't think like a healthcare person. He said, it's all going to the cloud. I look at this and I go, what's happening to patient billing? I mean, revenue cycle, whatever that is so going to change. I have no idea where that's even going to go and how we're going to track it. But the point was that most of this stuff is not going to be managed locally the way it has been. We're not going to be installing in the teams we have that do project management. We've been in kind of this installation cycle forever, and I agree. We're done with that. We should be. At some point, it's not the Winchester Mystery House, and you know, we need to stop with this. That if any of you have ever been there, they've got stairs that go into walls and doors that open into nothing because right. Mrs. Winchester believed she kept building she'd never die. And we do that in healthcare, and we're kind of, we can't keep doing that. So we have to know when to stop and when to start directing away from our traditional way of doing things and move these more and more together. HIEs are going to do that. We're going to need to collaborate more. We're going to have to get all this stuff moved out of our arena. Mm-hmm. We had to manage it up until now. I think the hard part is going to be letting go of it.
How comfortable are each of you with having your entire EHR outsourced in terms of where it's located, data center, all that, at this point? And how comfortable do you think you'll be in the future?
Yeah, I think it's well, it depends on what you mean by outsourced. That's one of those words. It can mean a lot of things. But do I have to be able to go open a door and look at the blinking lights to have some sense that I have the utility? Because frankly, you think about it as a utility. The problem is, including Epic, and a lot of these applications, you can always have the vendor host, and we know Epic will be doing that, for example. Mm-hmm. Cerner's doing it successfully now. It's kind of cloud-based. It's cloud-like in some respects. Right. I've got 250 other applications, big and small, that don't necessarily lend themselves to that. So the first question is, do we need them? Secondly, you know, as we upgrade them, can they be hosted or can they go to the cloud? So we're working diligently through that. That's going to be a multi-year process. But and I didn't show the slides, but I have some rather embarrassing slides about our data center. I don't quite have the geographic proximity that John does, but it's like 25 miles over to the data center that Barry mentioned, which is not bad. But it's still
you're in a bigger seismic.
Yeah,
area.
Right. But our seismic thing goes all the way to Yellowstone, I think. I don't know, it's big. And so it's not good. So I'm in the midst of partnering with one of my colleagues in the region. Mm-hmm. And to really not extricate ourselves from the data center business, but to turn it into more of a utility. And frankly, there's something we can share with others, but to lower our costs, increase our reliability, and give me real geographic diversity with another facility in Arizona. While we begin to offload all of those things, even together, to our vendors and other places. If you've seen Google or Amazon and their board members have asked, what's the cloud? And they actually sometimes, I think, believe it's a cloud. And I showed them some pictures of what Google and these data centers look like, and they're incredible. Yeah. And they happen to have all the Google colors. They're really kind of cute. But they're amazing. They make their own servers, things that we could never do. Correct. But they're taking their costs way down. These are, you think about non-value-added costs. This needs to work. It's not delivering care. So it's a fight. It may be a decade as we rationalize these services, but we got to turn it into a utility.
Great, thanks.
When we went to Epic, we went into a colo data center, and I think, so certainly data center physical management, I mean, we've got some on-site stuff for packs and things that are very network dependent, but the old big iron data centers, but there's still hospitals that are building them today, which just, I question that a lot. I think we're doing more and more. Every time we're making a decision, it's usually not about, we're not taking our current tier ones and sort of doing an evaluation, but when we're at the replacement mode, like our time and attendance system, which we decided to do on premise, we're actually doing a conscious decision now. Our ERP is hosted by Amazon Cloud, and I mean really the public cloud infrastructure. Office 365 will be moving to next year, so I see more of that. It's really a financial decision. You can commoditize it. There's just so much, as you were saying, Scott, or alluding, what I heard you were saying, there's so many niche healthcare systems that aren't really designed. They didn't make an architectural decision about the infrastructure. You know, it was an anesthesiologist and a buddy that programmed something. And so it can't really be commoditized. So we're still living in an era of lots of niche products that are still pretty, patchwork together. I'm okay doing, those are strategic, those are, I mean, they're not strategic, but we have an operational clinical dependency on it. We'll be doing that probably through the end of this decade. But I see, by the time I retire in 10 years, there'll probably be less and less that's, if not anything at all, that is, I mean, currently we don't have an on-premise because we're a colo data center. But even when you say cloud, I mean, I take that to mean truly the running on, buying CPU cycle, not even Cerner's software as a service. I don't consider that a cloud. But I think more and more of our industry will go that way.
Thanks. Well, great. I'd like to thank our panel. We're at our time, 4:15 here, so we were told to end at this time. But thank you all for, I think, a great talk.